In this lecture, we are going to have the clinical manifestation, diagnosis, and treatment of bronchiectasis. So first of all, let's have a look at the clinical manifestations of bronchiectasis. The most common clinical manifestations is a persistent, productive cough with ongoing production of thick, purulent sputum. It will get worse in bed in the morning and at night. An increase in sputum volume and purulence indicate an acute exacerbation of lung infection. So if we put a large amount of purulent sputum there for a while, it can be divided into 3 layers. The upper layer is the foam mucus, while the middle layer is serous fluid, and the lowest layer is pus and necrotic tissue. However, it is noteworthy that in some patients, repeated hemoptysis may be the only symptom. Clinically, we call this situation the dry bronchiectasis. If the hemoptysis is in a large amount of bloody sputum, it is dangerous and needs emergency management, or otherwise it may lead to death of the patient. In some patients, they might have dyspnea and wheezing, especially in patients with widespread bronchiectasis or the underlying COPD. Physical findings often include crackles and wheezing during long auscultation, and in some patients, they might have clubbing fingers, looks exactly like this. This clubbing finger is a result of hypoxia for a long period of time. If the patients have situations as follows, then at this time we consider that she has a chronic acute exacerbations, including the increased cough, change in nature or sputum, increased dyspnea, and wheezing, fever, fatigue, malaise, lethargy, or decreased exercise tolerance. Then let's move on to the diagnosis of bronchiectasis. The diagnosis is usually based on presentation with a persistent chronic cough and sputum production, which is accompanied by consistent radiographic change. Although the chest X-ray is non-specific for bronchiectasis, the presence of tram tracts or ring shadows strongly indicate that the airways is dilated, and it is consistent with bronchiectasis. As you can see from these pictures, there are tram tracks, which exactly looks like the tram tracks of the train, right? As well, there are some near round, transparent opacities there. They are all strong signals for bronchiectasis. If we put some radio contrast agent injected into the bronchioles, then we can see how the bronchioles or bronchi goes inside the lung under the bronchoscopy. As you can see, the left picture represents the normal bronchi, while the right picture, we can see that the grape-like puzzles with the thin, fragile sacs. That is what we have, what we call the cystic bronchiectasis. Well, on the other hand, when compared to chest X-ray, chest CT is more specific for bronchiectasis, and it is the imaging modality of choice for confirm the diagnosis of bronchiectasis. As you can see from this CT as chest CTs, it is more specific for bronchiectasis. The CT findings including the tram tracts, which is parallel, as well as the signet ring sign. As well, we can see the tree in bud pattern. This pattern is because the bronchial wall thickening in the dilated airways with insipid secretions. in these two dilated airways, we can also find two common characteristics. The first one is called the cross-sectional area inside the airway, which have a diameter at least 1.5 times of the adjacent vessel. Secondly, lack of bronchial tapering. It means that the presence of tubular structures within 1 centimeter from the pleural surface. Okay, another evaluation of bronchiectasis is a workup to determine the underlying etiology. So, evaluation of focal bronchiectasis almost always requires bronchoscopy to exclude the airway obstruction by an underlying mass or foreign body. As well, a workup for diffuse bronchiectasis includes analysis of the major etiologies with an initial focus on excluding the cystic fibrosis, which is usually seen in European peoples, remember? Okay, last but not least, pulmonary function test can also be considered as an important component of a functional assessment of the patient. And other investigations typically performed at diagnosis include the blood tests, sputum cultures, and sometimes tests for specific genetic disorders. Last but not least, let's have a look at the treatment of bronchiectasis. First of all, antibiotics targeting the causative or presumptive pathogen should be administered in acute exacerbations, usually for a minimum of 7 to 10 days, and perhaps for as long as 14 days. Secondly, bronchial hygiene is very important for the treatment of bronchiectasis. There are numerous approaches used to enhance the secretion clearance in bronchiectasis, including hydration and mucolytic administration, as well as aerosolization of bronchial dilators and chest physiotherapy. You might ask, what is chest physiotherapy? As you can see from the picture, it is the postural drainage. This kind of method is getting in positions that make it easier for mucus or sputum to drain out of the body. Besides, we also have traditional mechanical chest percussion via the cup-shaped hand clapping to the chest, using the chest percussion. Caregivers could gently clapping parts of the body to remove the mucus or sputum or fluid from the lungs. And these cup-shaped hands will help to break up the fluid inside the bronchioles. Besides the above-mentioned two methods, there are also other physiotherapies, including the use of devices such as an oscillatory positive expiratory pressure flutter valve or a high-frequency chest wall oscillatory vest. All these methods could be used to help the patients to get rid of their mucus or sputum out of the body. In some situations, glucocorticoids could be used as an anti-inflammatory therapy. Especially in some situations, surgery or lung transplant could be considered, such as the recurrent lower respiratory tract infection and severe hemoptysis, as well as the bronchodilasis area less than 2 lobes and age from 10 to 14 years old, as well as good condition in other organs, for sure with no contraindications. And these situations, we should consider a surgery or lung transplant for the patient. That's all for this lecture. Thank you.